Good afternoon, my name is Eva de Jongh and I'm an Internist-Hematologist at VU Medical Center. And today I want to talk to you about leukemia and especially all the different diagnostic procedures we use in our everyday work at the hematological department. I present to you a 31-year-old male. He was in his usual state of health until he began experiencing fatigue, shortness of breath and bleeding of gums. So he went to his primary care physician. And after a first visit, he was noted to have a very abnormal blood count. He had a hemoglobin level of 6.2, blood platelets of 44, and a leukocytosis of 102. So his primary care physician sends him to the emergency department and you're the attending on call. You suspect it could be some kind of leukemia, but what do you do to differentiate between all the different types of leukemia? Leukemia is a group of cancers that usually begin in the bone marrow and result in very high numbers of abnormal white blood cells. These white blood cells are not fully developed and are called blasts or leukemia cells. Clinically and pathologically, leukemia is divided into a variety of large groups. The first division is between its acute and chronic forms. Acute leukemia is characterized by a rapid increase in the number of immature blood cells. The crowding that results from such cells makes the bone marrow unable to produce healthy blood cells. And immediate treatment is required in acute leukemia because of the rapid progression and accumulation of the mature cells. Chronic leukemia, on the other hand, is characterized by the excessive buildup of relatively mature but still abnormal white blood cells. Typically taking months or years to progress, the cells are produced at a much higher rate than normal, resulting in many abnormal white blood cells. Whereas acute leukemia must be treated immediately, chronic forms are sometimes monitored for some time before starting treatment. In this slide, you see the main differences between acute and chronic leukemia, especially the differences in the severity of anemia and thrombocytopenia, as well as the presence or absence of enlarged lymph nodes or an enlarged spleen, can help you in determining whether this is more likely in acute or chronic leukemia. One aspect I want you to focus on is the white blood cell count. In chronic leukemia, the white blood cell count is almost always increased, but in acute leukemia, it can go either way, increased or decreased. Additionally, the diseases are subdivided according to which kind of blood cell is affected. This divides leukemias into lymphoblastic or lymphocytic leukemias and myelocytic or myeloid leukemias. In lymphocytic leukemias, the cancerous change takes place in a type of marrow cell that normally goes on to form lymphocytes. Most lymphocytic leukemias involve a specific subtype of lymphocyte, the B cell. In myelocytic leukemias, the cancerous change takes place in a type of marrow cell that normally goes on to form normal red blood cells, other type of white cells such as neutrophils and platelets. Combining these two classifications provides a total of 4 main categories: acute myelocytic leukemia, acute lymphocytic leukemia, chronic myelocytic leukemia, and chronic lymphocytic leukemia. And within each of these main categories there are typically several subcategories. But how can we distinguish all these different kinds of leukemia? Just a full blood count won't give us all the clues we need, so there's more. I want to talk to you about all the additional techniques and diagnostic procedures we use to get a clear view of the exact type of leukemia. The investigations we complete and the results we generate have an important bearing on the patient's management, the treatment plan, and its prognosis. You can use either blood or bone marrow for these techniques, depending on the quantity of leukemic cells in blood. Well, first of all, we have the blood film examination with a May-Grunwald-Giemsa stain. The blood film can give us all kinds of important information regarding the appearance or morphology of the blood cells. We look for white blood cell, red blood cell, and platelet abnormalities. In chronic leukemia, we can find distinct different features and white blood cells. For instance, when suspecting a chronic lymphocytic leukemia, we look for so-called smudge cells. In chronic myelocytic leukemia, CML, you see increased granulocytes of all types, typically including mature myeloid cells. It almost looks like you're actually watching a bone marrow aspirate because you see a number of cells that normally can only be found in bone marrow. In acute leukemia, we often find blasts or leukemic cells. At first, they all look like beautiful purple cells, but if you look more closely, you will notice specific details. The size of the blast, the amount of cytoplasm, the nucleochromatin pattern, the presence of nucleoli, and, as seen in the next slide, the presence of Auer rods, which indicate a malignancy of myeloid origin, as you can see here. In contrast to the myeloblast, the lymphoblast is a much smaller blast, with almost no cytoplasm, indistinct nucleoli, and no Auer rods. The problem is that only 50% of myeloid malignancies exhibit Auer rods within the cytoplasm of blast cells, so we need more to differentiate between myeloblasts and lymphoblasts. So we use specific staining methods, cytochemistry, to confirm the presence or absence of particular markers within cells. Most commonly used in our institute is the Sudan black staining method. It can be used to identify granulocytes and sometimes monocytes. A positive reaction provides a dark brown, sometimes black granular inclusion within the cytoplasm. Strong reactions are seen in promyelocytes, myelocytes, and therefore in acute myelocytic leukemia. But a negative reaction does not distinguish between other types of acute leukemia. And the inability to differentiate between these blasts was one of the important considerations with the implementation of immunophenotyping. The process of immunophenotyping involves the use of monoclonal antibodies. Those are directed against intracellular and extracellular cluster of differentiation antigens, of which about 350 are currently recognized. These are called CD markers. Monoclonal antibodies are joined to fluorochromes, molecules which irradiate light at a particular wavelength when excited by a laser. The light emitted from each fluorochrome can be measured using a detector and is used to identify whether or not a particular CD marker is expressed by a specific population of cells. The identification of lineage is of vital importance in being able to establish the correct diagnosis for a patient with a hematological malignancy. For instance, if a population of cells express CD13, CD33 and CD34, we can be confident that these cells are of myeloid lineage. Immunophenotyping can also be used during follow-up of the disease. In this example, you see the results of a 6-year-old boy with acute lymphocytic leukemia. At diagnosis on the left, there were 87% blasts with a specific phenotype, positive for CD10 and TDT. And after a first round of chemotherapy, only 6% blasts were found using this specific technique. Now we move on to cytogenetics, which gives us additional diagnostic and prognostic information. Many leukemias and other hematological malignancies are characterized by specific chromosomal abnormalities, including specific translocations. The importance of analyzing these cytogenetic abnormalities is clear when you look at this slide, with specific abnormalities found in AML, acute myelocytic leukemia, associated with a completely different prognostic outlook. Karyotyping will identify any numerical or structural chromosomal abnormalities. This is a normal male karyotype, whilst the patient with a CML has a completely different karyotype, which is shown in this slide. It has the specific translocation 922, which results in the formation of the so-called Philadelphia chromosome, an unusually short chromosome 22. In some cases, FISH, fluorescence in situ hybridization analysis, may detect gene rearrangements that are present in low frequency and not observed in initial chromosomal analysis. And FISH uses fluorescent probes to bind in a complementary fashion to the particular chromosomal segments to be investigated. As an example, I show you the results of FISH analysis in a patient with acute promyelocytic leukemia. and promyelocytic leukemia is characterized by a specific chromosomal translocation 1517. The translocation fuses the PML gene, which is shown in red, to the retinoic acid receptor gene, which is shown in green, and this results in the production of a so-called PML-RARA fusion protein, seen in yellow. And this type of AML, called AML-M3 or APL, is distinguished from other types of AML by its responsiveness to all trans retinoic acid. It has a relatively good prognosis. In certain situations, the tests outlined so far are insufficient for us to be able to obtain the appropriate diagnostic and prognostic information for a particular disease, and further information can be obtained by using molecular techniques. For instance, polymerase chain reaction, PCR, DNA sequencing technologies, and gene expression profiling all provide important information. For instance, quantitative PCR performed at the time of diagnosis may also provide a baseline against which the response to therapy can be monitored. For example, CML. When a patient is treated with a tyrosine kinase inhibitor, like imatinib, fewer detectable leukemic cells are present, and the normal cytogenetics and FISH analysis have become limited in providing information on the kinetics of low-level disease. PCR, on the other hand, is capable of detecting one leukemic cell in approximately 100,000 to 1 million normal cells. And the diagram shows how BCR-ABL transcript levels change over time in a patient with CML treated with imatinib. So, back to our patient. When you see him at the emergency department, you notice he is alert and awake, and he has normal vital signs. There are no signs of fever or hypoxemia. But you do notice he's quite pale. And on thorough physical examination, there are no evidences for enlarged lymph nodes or an enlarged spleen. You obviously already know his full blood count with an anemia, a thrombocytopenia, and marked leukocytosis. So with all this information combined, you think it could be an acute leukemia. And obviously you want to take an immediate look at the blood film. But that takes about 30 minutes before the staining is complete, so you have to wait. So after about 30 minutes, you're able to take a look at the blood film. And at first glance, you obviously all see these purple large cells, which look like leukemic cells. They look like blasts. And what you notice on the other hand is that there are hardly any signs of normal hematopoiesis. You find no signs of normal granulocytes, and you find no signs of blood platelets. Normally in each slide there should be a couple of blood platelets, but there are none in this slide, which obviously is consistent with the results from the peripheral blood. And when you see these blasts, you know you have to start looking for features that could distinguish between lymphoblasts and myeloblasts. And when you search a little further, you find a blast which has a small hour rod in the cytoplasm. And you now know this is consistent with an acute myelocytic leukemia. To confirm that, we also performed a Sudan black stain, which I will show hereafter. And after focusing, you see that all these blasts turn dark brown, almost black, which is also consistent with acute myelocytic leukemia. So we now have the very strong suspicion of an acute myelocytic leukemia. And after a couple of hours, the immunophenotyping results return, and they confirm that suspicion. It shows 96% blasts, and all these blasts are positive for CD34, 117, 13, 33, and MPO. So we now know it's an acute myelocytic leukemia. And the patient needs to be admitted right away and needs to start on high-dose chemotherapy right away, consisting of anthracyclines and cytarabine. After a couple of weeks, the other additional diagnostic results return, and cytogenetic analysis shows multiple abnormalities, and molecular diagnostics show he has an EV1 overexpression, which is associated with a very poor prognosis. Luckily, in a bone marrow aspirate we perform at day 21, there are no signs of residual leukemia. So hopefully we'll be able to give him another round of high-dose chemotherapy before proceeding to an allogeneic stem cell transplant, which could give him his best chance of achieving a long-term remission. Thank you for watching this video.